Hello, everyone. I am Pira Nada. Welcome to Rappler Talk. Today, we have with us a very special guest, Dr. Manuel Dayrit, our former health secretary, here to talk to us about the latest developments on the COVID-19 pandemic in the Philippines. So, hello, sir. Thank you again for joining us, for being here.
Hello, Pia. Hello, everyone.
So to put it in context lang, no, we're nearing the end of April and the IATF is set to meet to discuss the new quarantine classifications for the month of May. And this current MECQ that we've had for 2 weeks now is supposed to end on April 30. So
Mhm.
meanwhile, the Department of Health wants an extension of the MECQ. And at the same time, Metro Manila hospitals are still at critical ICU capacity. We're still hearing of more than 70% critical capacity, and so they're still full. Like we still have this crisis going on. We're also poised to hit the 1 million mark in COVID-19 cases, a very grim a milestone in this pandemic. And we've also been having vaccine rollouts, but people have said it's slow because of the limited supply. So these are, the current situation we find ourselves in, and this is the context of our interview. So, Doc, siguro we can start with the most pressing question: what's on everybody's mind? Do you think NCR Plus should shift to GCQ, or do you want an MECQ extension?
Yeah, I think you've mentioned the considerations already. One, cases are still high, although there's been a slowdown in growth. But the growth rate of cases is still positive. And I think that's translated to a reproductive rate that's greater than 1. Okay. Number 2, the hospitals are really still full. And therefore, another consideration there with hospitals full would be possible deaths. Okay, with increased cases, you have more deaths. And I guess a third consideration is essentially the vaccination rate. And what is the vaccination rate in the cities, particularly in NCR? And we know that really the vaccination rate is very low. We've done priority A1 and priority A2, but if you look overall, the vaccination rate is what, 1.7% nationwide. And in the NCR cities, I think we'll be lucky if we have 5%. So that translates to still very many susceptibles in the population. So I think the trade-off here is, well, do you want to risk it? Because it could still get worse. And therefore, I think that's what the decision makers have to decide, considering also the other factor of the economics. Therefore, on the side of prudence, I'd lean towards extending it.
Mm-hmm. Earlier in the Malacanang press conference, I heard Presidential Spokesman Harry Roque say that the reproduction number in NCR has gone below 1. It's now 0.91, 0.93, and the same data is being shown by the Octa Research Group. So they're saying that this indicates that the past 4 weeks of ECQ and MECQ were effective. Do you also agree with this assessment?
Well, the figures that I saw were greater than 1, but if they say it's now less than 1, then so be it. But it's a very volatile situation. You can just have super spreading events that can just wipe out that gain. So I think one thing that we could also factor into thinking about this is that it's not just in the Philippines or even in NCR where the surge is. It's globally. So there is this global pattern of surge everywhere. For whatever reason, the surge is occurring. And a lot of that is probably also variant driven, as well as, mobility. And therefore, we are part of that global surge. And despite, some gains, we're not sure. And I think really it's gonna eventually come down to, are we willing to really have to see the situation where our hospitals can't accommodate patients that actually need care? And I think that's going to be the critical aspect that decision makers are probably going to consider very, very heavily.
So you already mentioned the tragic situation we've been seeing in the last weeks, where we saw hospitals full and patients even waiting and dying while waiting for treatment. So we know naman that the quarantine classification system was designed to prevent such an overcapacity, diba? That's why we have a scale up system where we can go to GCQ if we have this much available beds in hospitals, and then we have to upgrade to MECQ when nagkukulang na. So my question is, it seems that the system was designed to prevent the scenario, and yet the scenario happened. So could government have prevented this situation, this tragedy, and where did it go wrong?
Well, I think government tries, no? But really, when you think about it, any expansion of supply or of capacity is really puny given the surge that actually happens. Increasing by 120 beds, I think that's already a huge gain because that's 120 people that can have care. But when you think about the surge really 10 times that, then we know we're really overwhelmed and you can't increase capacity even more. So that's really the capacity of our system, I think. Sad to say. That's it. That's as far as we can go. And anything above that, it's spilling over to people that are not cared for and people that are going to die. And therefore, I think that's the decision that has to be taken by the civil leaders. Are they going to be able to allow that? Or are they going to look the other way and say, well, consider those casualties that we can bear? And of course, it's families and individuals that will have to bear those casualties.
So you're saying, Doc, that every system has its limits. So one of the best ways to prevent that limit from being reached is to just prevent the infections in the first place. But I'm also looking at, for example, what we can do within the system to make it more efficient and to prevent this scenario of overcapacity. Before, in your previous interviews, you mentioned the fact that we could maybe make it more efficient for people to find beds and for maybe local governments and hospitals to better man the flow of patients so that only those who really need critical care end up getting those very limited beds. So what can the government do now, as early as now, since we're now recovering from the surge we just experienced, or it appears that we're in this little area where we're lowering the reproduction number? What can we do now so that we are better prepared next time?
I think they're already doing it already. Certainly, I know private hospitals are doing it. But for example, for critical care beds, they're making the emergency rooms alternative ICUs. And therefore, people are waiting in the emergency rooms for 2, 3, 4 days, waiting for an ICU bed. And then number 2, I think they're now expanding care to the homes so that people can be treated in their homes. Now, I don't know how extensive this is, okay, and whether it's making an impact, but I think they're doing that already. So they're already stretching supply. I think they're activating isolation centers again. If I'm not mistaken, they've made East Avenue Medical Center a dedicated hospital for COVID-19. So there, you could probably expand capacity by several hundred. But if you're going to see thousands of cases coming in, then it still overwhelms whatever expanded capacity that has been created.
You say that the variants could have also contributed to the surge, and the government says the same thing. What then should our government do now to prepare for another surge or introduction or entry of new variants?
Pia, given the way this virus behaves, I think our best bet is vaccination. So that's securing the procurement. And I know there are challenges there, cutting the contracts and the deals with all of the manufacturers, which are under pressure. That is also, problematic at the moment, with India being the biggest vaccine manufacturer really not producing enough, okay, because of their own problems in India. And the fact that, as I understand it, things that they need to create the vaccines still need to be imported from the US. And I think they're sorting that out. But that's what we have to do. We have to just slowly and surely increase the vaccination rates of our population over this next year or this next 8 months. I think that's the goal. And therefore, what I guess we can see here is a situation that ebbs and flows, that we go in and out of partial lockdown just to contain and limit the spread. And in the meantime, just incessantly drive the vaccination campaign towards reducing the number of susceptibles in our population. And as you know, we're targeting a herd immunity of 70%. That's 70 million people. We vaccinated, when I last looked the other day, 1.7 million. So 1.7%. 1.7% to 70%. Okay? When you start thinking about those numbers, can we reach 70%? Or are we just going to reach a fraction of that? And how much a fraction of that are we actually going to accomplish? I think that's the biggest question that we have to answer.
Do you see any lapse in how the government is carrying out the vaccination campaign?
You know, Pia, when you say lapses, it's like asking what could we have done better? Certainly, looking back, if we had procured vaccines much, much earlier, you know, we had started the procurement in October, you know, thanks also to the foresight and collaboration of the private sector here. But in October, you know, many of these vaccines, they still didn't have their EUAs. Okay, and so the problem there was, are we going to spend and invest in vaccines that we're not sure are going to go on stream? Okay, so in hindsight, we could have said, could we have procured better, faster? Could we have gone into the queue much faster? You know, we can only talk to the people who were actually trying to negotiate at the time. So that's one. Could we have procured faster and better? Okay, and I won't answer that question. Let the people that were negotiating answer that question. And then, of course, the other is really just tightening up our pandemic control functions. And we know it was we actually have a very leaky system. Okay, contact tracing is not being done as well as it should be, you know, for various reasons. Our testing, you know, at least thankfully works. Okay, we're testing as much as 55,000 to 60,000 cases a day now. But when you look at it, the positivity rate, means say the number of positives per 100 tested, is 17 to 20%. What that means is that there's just a huge there's just such an intense transmission that's going on. And actually that positivity rate is reflected in other countries. That's the positivity rate in India, I think, at the moment. Okay, and in other countries. So, you know, could we have done better? Perhaps. I think what we should look forward now to is how we can just drive down or drive up the vaccination so that we drive down the number of susceptibles. And we have our work cut out for that. Because still, a large number of our population, you know, are not convinced about vaccination. And therefore, I guess looking forward, government is to think about, what about those people that really refuse to be vaccinated? And that could be as high as 30 to 40%. What alternatives can we give them? And I think that's one question that has to be answered.
Mm-hmm. Vaccines are, Carlito Galvez Jr. says that if we are successful in their campaign, we could expect herd immunity by October or November, and for that impact to be seen in our infection rate. Do you think this is a realistic expectation? And what do you think it will take to get us to that level?
You know, that's really a very ideal target. To get to that rate, we have to be doing as high as 350,000 to 500,000 jabs a day. Where are we now? We're at around 44,000 jobs a day, which means we have to ramp up by 10 times and very quickly. Because if we ramped up by October, November, that's towards the end of the year, we have to be ramping up by June or July. As soon as these new deliveries come in, they should be being jabbed into people's arms immediately. And, I've seen many of the discussions on the operations. The operations are tough. They're very, very, very complex. Setting up the sites, okay? Just making sure that the supply side is intact, that you have the people there, that they're trained, the sites are there, it's all organized. That's one, okay? And then there's the demand side. It's just master listing the people who will be vaccinated, okay? And making those master lists. I know it's a big, big headache. Finding these people out there who will be part of the master list so that they can be, notified and vaccinated. And I know LGUs are struggling with that. So when Secretary Galvez mentions that, he's mentioning the ideal. Okay, that's the stretch goal. If we can do it, great. But looking at all of the operations and how complex and complicated they are, I think it's realistic to say that we'll probably hit a fraction of 70 million. How big a fraction, we can see. But we now have 1.7 million vaccinated. If we were able to vaccinate even 35 million by the end of the year, and that's 50% of the 70 million target, I think that's a huge accomplishment already. But, that means we still have to go on to 2022 to make sure we reach the 70 million.
So you mean to say, Doc, that you don't think we'll reach herd immunity this year?
I think it's a stretch goal. Given, our operations. And let me tell you why I think so, okay? What are the operations for vaccination? The main engines of that are the LGUs, okay? So you've got the LGUs in NCR, which are pretty well organized, okay? Then you've got the LGUs in the provinces, those adjacent to NCR, and then elsewhere, Visayas and Mindanao. You start asking yourself, what's the capacity of those LGUs to vaccinate? Okay, considering that they're used to vaccination levels of 2 million per year for children. Okay, and then aside from the LGUs, there are complementary or supplementary efforts that private sector can do. And private sector, for example, right now, as I speak, is already supporting NCR cities with creation of vaccination sites. And when I say vaccination sites, they're creating mega sites that people can go to. Okay, but then that's creating the site. Then you have to think about supplying these sites with the vaccines, okay? And that's one of the issues also, because private sector also have their own assignment, so to speak, of vaccinating their own people, okay, in the private sector as a contribution to the national effort. So when you think about those operations of setting up the sites by the LGUs and complemented by private sector, the sum total of that ideally should reach 70 million by the end of the year. And that's why I'm saying that, given the operations capacity that we have now, it remains to be seen if we can actually do that. My sense is we're not going to do 70 million this year. That's my sense. But as I said, it's a stretch goal. And I'd be ecstatic if we were able to reach 70 million this year.
What are your policy recommendations to hasten that? Because, like you said, the private sector could be a game changer since they have the resources, the motivation to do this to help boost our vaccination drive. So, what do you think government should do to make this process faster? Like, what help should they be asking? Who can they work with? I mean, what do you think?
Well, there are two things that come to mind. Government really, particularly national government, has to behave in a way that it enables and empowers. What I see a lot of is directives from national government to local government. Do this, do it this way, etc., etc. The question you have to ask is, how enabled and empowered and supported our local governments to do that? Okay, and I'm not going to answer that question because that's a question that actually LGUs themselves have to answer. The second is, I think national government really has to invest. And when I say invest in pandemic control. I mean, if money was oxygen, I think our pandemic control efforts are in respiratory distress. You have to invest in pandemic control, particularly in your frontline facilities.
What do you mean, sir, by pandemic control? Like, what is it? Equipment?
That includes testing, contact tracing, okay, and treatment. For example, under treatment, a lot of our hospitals are not being paid their health reimbursements. So how are they going to operate effectively? We have to invest in that. I mean, consider the pandemic control effort an economic enterprise in and of itself. Because by investing in it, you allow the greater economy to open up. And I think national government could actually improve in that. Well, in fairness, there's been the Bayanihan 1 law, there's the Bayanihan 2, there's the Bayanihan 3. But you hear reports that, you're not sure how the money's flowing and if it's actually getting to where they should be getting. And you keep getting consistent reports of hospitals not being paid for reimbursement. So those things need to be fixed and really fixed well. So that's the other policy recommendation. Invest in pandemic control and consider that an economic activity in and of itself.
What level of investment would you deem sufficient?
This is the billions. This is in the billions. I'll let the economic people compute that working with the planners in government. But certainly this is going to be in the billions.
Do you see anything systemic in the lapses? Because, for example, I heard you in another interview say that the structure of the IATF decision making, it's quite slow. Like it's collegial, and then you have I know for a fact that that Secretary Galvez has a weekly, means sometimes even more than once a week, meetings with Metro Manila mayors, and I guess that would be partly to address your concern about the dynamics or tighter coordination between national and local. Do you think that a bigger overhaul in structure is needed so that we can have a better response next time?
Well, that's really a tough question. It has to do with, do you want to change the IATF? My simple answer to that is we have to be very careful about any organizational changes at a time when the situation is already very volatile and uncertain. The pandemic machinery, the pandemic control machinery, the public doesn't see what happens behind the scenes. But when you see it up close, it's a whole interaction between national government and its different agencies at that level. That includes DOH, DILG, DSWD, the information people, etc., even the science people. And then interactions with local governments, which number in their thousands. And then working with all of the other stakeholders. including private sector. And then trying to get that system just coordinated and doing the execution as seamlessly as possible. What essentially people appreciate is, one, how government communicates, and oftentimes what they hear communicated is difficult for them to grasp. And then the other is the outcome. Okay, are vaccination sites ready? You know, are contact tracing efforts being done? They see it according to these different patches of outcomes. You know, changing, for example, the topmost committee for that, you know, you ask yourself, how then will that necessarily make things better in a whole situation that's so intricately interwoven at a time when you already have a volatile situation where the virus, the enemy, surges, you know, anytime, and your forces, you know, get exhausted. If anything, that could be done better, okay, and should really be studied. It's how you're financing the pandemic control operations and actually populating it with human resources. Because you need to find a way of reinforcing people in the front line and giving people rest. And that has to be a routine sort of thing, so that there are people that have to be in the back rooms planning that at different levels, you know, in the hospitals, in the LGUs, and so on and so forth. All of that should be happening. And I dare say that we're not doing as much of that as that we probably should be doing, which is why we're stretched out, you know, and the frontliners, you know, they reach a breaking point and then, you know, they just have to call for timeout.
Oh, outside vaccinations, because we all know nga this is the game changer here, like if we can get herd immunity. But before that, since we will most likely have to reopen the economy because of the hunger rates, poverty, I mean, our concerns on the economy and livelihood, do you think there's anything we should change in our quarantine classification system, the way we enforce these restrictions, when we get to that point where we have to reopen the economy, but at the same time have to curb the transmissions?
Well, you know, all of these quarantine enforcement systems have their difficulties of monitoring them, particularly when you don't even have an app for monitoring, which is one of our biggest problems. You know, we don't even have an app for monitoring quarantine and isolation. So the other approach really here, and you know, that would really mean persuading, you know, people to be disciplined. Because in the end, people by and large have to be disciplined. And I think, you know, Filipinos by and large, they follow. But I think, you know, the way this situation works is that you could have super spreading events anytime. You could be maintaining, for example, a situation where there's lockdown, but you could have a super spreading event anytime during that lockdown. You know, we've heard seen politicians or whoever have their parties, okay, and so on and so forth. And that sends out wrong messages. And also in the provinces, you know, I was just talking to one province, the governor, I won't mention their names, but they have a low transmission level in their province. But they've been able to document that when they have surges, they can trace it to super spreading events. People that gather for whatever, you know, for town fiestas or whatever. And you've got a super spreading event there. So it's that ability to be able to convince the population to, you know, keep keep disciplined, but also provide the type of monitoring and enforcement where you can discipline people who break the rules. And that means a very, very efficient and effective system for monitoring what goes on in your localities.
Mhm. We've seen some data. For example, in Quezon City, they've been able to see that a majority of transmissions happen in the workplace, and that, for example, transmissions in transportation, public transportation, they're not as big. So, might you have seen any recent data that could maybe enlighten us as to where the transmissions happen most of the time? And if we've identified this, what do you think are interventions we should introduce to address those surges?
I think that the surges actually occur in places where people gather, particularly where they relax minimum health standards. And so they happen indoors when people congregate, particularly to dine and start relaxing. So even if you have 20 people there, okay, you could already have a super spreading event. That 5, 6, 7 of them will get infected, and then they bring it home to their families, and then you have a spread again. Okay, and then I guess super spreading events where you have large mass gatherings for some event, which I think was the situation in India, where you had really mass events, particularly with their pilgrimages and festivals. So I don't think we're having that here. But these are all the possibilities for super spreading events.
Mm-hmm. And then, Dr. Dayrit, I would also like to bring up this issue of controversial treatments to COVID-19. I mean, for one thing, the issue on ivermectin has reached even Malacanang, with the president himself ordering that clinical trials start here locally, because previously the DOST was saying, oh, we don't need to hold domestic clinical trials because anyway, there are many abroad. So, sir, what is your stand on this public debate on ivermectin as a COVID-19 treatment, given that it's still not approved by the FDA for this, and the World Health Organization also cautions against this?
Well, Pia, some colleagues in PASE, that's the Philippine American Academy of Science and Engineering, we wrote up you might say, a commentary, which was actually published a couple of days ago in the Inquirer. But it's a very controversial issue. And it really boils down to how you interpret the scientific studies for ivermectin. And the interpretation has to do with the selection of the studies to include in your meta-analysis, as they call it. A meta-analysis is a way of integrating many studies in order to come up with one conclusion. And that conclusion is, in what direction does this intervention seem to be pointing? In the direction of reducing infection or no effect? Okay, no, doesn't help. Okay, and it boils down to people who are against it saying that, the studies that we've selected, which are very, very strict and rigorous, don't give you that conclusion that it works. And those that are for it will say, but the studies we selected, and we have been more liberal in accepting them, do show that they work. So it's a gridlock. So the only agency that can break that is the FDA. And the question really that we pose to the FDA is, given this gridlock, would you consider putting ivermectin in the drugstores, meaning to say, by approving it, because it's it's an accepted drug, by approving it for antiparasitic use. By approving it for antiparasitic use, you can put it in the drugstores and people can buy it. Okay, so it's available. And you want it available because there's a gray market where products of ivermectin are being sold and used, but you're not sure about the quality of manufacturing because you haven't regulated it. But if you put it in the drugstore, you know that the products there are well regulated and are shown to be quality assured, and then give the doctors the prerogative to use it off-label for COVID-19, depending on their own assessment of the needs of the patient, particularly if the patient is willing to use it. Okay, so I don't necessarily, I'm not really saying that ivermectin works or not, okay? Because as I said, you've got a gridlock in the scientific opinion. But we're suggesting a way in which you address both concerns and address the other concern that you could actually be proliferating products of low quality because there is a demand for it and people are going to use it. So that was what we suggested in the commentary.
Mm.
Make it available is what we're saying. And let the doctors decide about using it. If there are doctors that say, we don't think it will work, then these doctors don't prescribe it. And those doctors that say, well, I think they're going to work, and my patient wants it, then they can use it. Under pandemic situations or conditions, then you address the concerns of both. Those that don't want to use it and those that want to use it.
Is there a danger of people depending on ivermectin, given what they see on social media, for example, that if you take it, you no longer need a vaccine? I mean, how then do we address these concerns that they could, in fact, feel complacent by taking ivermectin? Because that's something that some anti-ivermectin people are saying.
Well, this is the thing. Okay, you have to be strict because you put it in the drugstores, but you don't sell it as an over-the-counter drug. It still is a prescription drug. And therefore, somebody that wants to use it, even for preventive, will have to find a doctor who's going to prescribe it for him or her. Okay, it's not over the counter. You can't buy it like paracetamol. But it's available as a prescription drug. And you open the door to off-label use, meaning to say, use not as an antiparasitic, but as a COVID-19 purported remedy.
Okay. Doc, I'm on to my last question. We still have, as you said, a minimum of a year, perhaps, before vaccinations or herd immunity is reached in our country. So, matagal pa to, basically. What is your advice to Filipinos and people just trying to get by, trying to stay safe, but at the same time knowing that, diba, a year is a long time to be stuck at home. A lot of people are feeling pandemic fatigue. What is the best we can do right now to keep our health system afloat, but at the same time still keep our lives afloat, our jobs, the things that make life worth living? Given that so many people feel a lot of people feel like giving up because of the situation we're in.
Well, I guess a lot of that is just finding ways to both shore yourself up psychologically, entertain yourself, make yourself feel useful. So I would say find new hobbies, find new opportunities for creating an income, and find ways of contributing to pandemic control. Because that way your attention is outwards and you're trying to contribute positively. I think the last thing you want people doing is feel sorry for themselves that they can't go out, and mentally feel down. And I think people are actually making those adjustments already. So where people are able to do that and where companies and communities are able to support people's efforts to find new ways of making a living, entertaining themselves, and reaching out. I think that's going to be better for all of us.
So at least there's a bit of hope in our discussion, right? I mean, there's something we can do personally to address the impact that this pandemic has had on our lives. So here at Rappler, we're going to continue to monitor the vaccination distribution, a very critical development in our country. We're also going to continue to monitor the changes in quarantine classifications and everything about how our pandemic response is playing out. So once again, thank you, Dr. Dayrit, for being here with us and for sharing your insights. And thank you everyone for watching Rappler Talk.
Thank you, Pia.